Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. In this module, we are going to discuss about myomectomy. So in the previous module, we dealt about the medical management, the uterine artery embolization and the ultrasound focus procedure as well. But in this module, we are going to deal about a minimally invasive procedure, which is myomectomy. So as we all know, we are going to divide this term into two. So it is myoma plus ectomy. So what do you mean by myoma? So myoma is also known as fibroid or leiomyoma. So the benign tumor of the uterus, which is the fibroid, which is also known as leiomyoma. So myoma refers to the fibroid and ectomy means removal. So we are going to remove the fibroid from the uterus. At the same time, you're going to preserve the uterus. So without having any disadvantage, you are going to preserve the uterus and at the same time, you're going to remove the fibroid in the uterus as well. So it is therefore a conservative management because you're preserving the uterus on one hand, which is a beneficial effect. At the other hand, you are removing the fibroid from the uterus, which is also a beneficial effect. So it is definitely a conservative management in the treatment of fibroid. Okay, so now this myomectomy can be done by 4 types. So it could be hysteroscopic myomectomy, laparoscopic myomectomy, abdominal myomectomy, and robotic myomectomy. So what is hysteroscopic myomectomy? As we all know, hysteroscope is a magnifying instrument which is inserted inside the vaginal canal of the female, and through the vagina you are going to visualize the interior of the uterine cavity, which is the uterine endometrium. So since this instrument can visualize only the interior of the uterine cavity, any type of fibroid which is going to be present in the uterine cavity can only be removed through this hysteroscopic route. So what are those fibroids which are situated in the uterine cavity? Those are the submucous fibroid, because submucous fibroid are those fibroids which are situated in the uterine cavity. And we have 3 types of submucous fibroid according to Figo, that is type 0, 1 and 2. So type 0 and type 1, more than 50% of the fibroid is situated in the uterine cavity. So since more than 50% of the fibroid is occupying the uterine cavity, it can be removed by hysteroscopic myomectomy. So submucous fibroid type 0 and 1 can be removed by hysteroscopic myomectomy. That is one indication. And the other is that any kind of submucous fibroid which is less than 5 cm in size. So any fibroid which is less than 5 cm can be removed by hysteroscopic myomectomy. But if in case the size of the fibroid is going to be more than 5 cm, it has to be removed by laparoscopic myomectomy. Right? It can be removed by laparoscopic or abdominal myomectomy as well. Is that clear? Less than 5 cm submucous fibroid type 0 and 1, it can be removed by hysteroscopic route. But if it is more than 5 cm, it has to be removed either by the laparoscopic route or the abdominal myomectomy route as well. Is that clear? Yes. So any fibroid which is going to be more than 5 cm, it has to be removed by either the laparoscopic route or the abdominal route. And submucous fibroid type 2. So what are submucous fibroid type 2? Type 2 is where more than 50% of the fibroid is occupying the intramural part and less than 50% only is occupying the uterine cavity. Since only less than 50% of the fibroid is occupying the uterine cavity, therefore it cannot be removed by the hysteroscopic route. So therefore it needs either the laparoscopic route or the abdominal myomectomy route. So more than 5 cm fibroid and submucous fibroid type 2, it has to be removed by either laparoscopic or the abdominal myomectomy route. So as we all know, laparoscope is also a magnifying instrument which is inserted through various ports in the abdominal wall of the patient, and through another port you're going to actually introduce the instrument through which you're going to remove the fibroid. So in one port of the abdomen you're going to insert this laparoscope, and you're going to make another port in the abdominal wall of the patient and insert the surgical instrument which you're going to use to remove the fibroid. So that is the laparoscopic myomectomy. And abdominal myomectomy is when you are going to make an incision on the abdominal wall. The most common incision which everyone has to know is Maillard incision. So this is the incision which is made in the abdominal wall, and This incision has to involve both the serosa, myometrium, and even the capsule of the fibroid has to be included through this incision. And once you're going to extend the incision into the capsule of the fibroid, and the fibroid has to be removed into two. Is that clear? Yes. So this is the abdominal myomectomy, and the fourth one is robotic myomectomy, is where through the robotic route the fibroid is actually removed from the uterus. So these are the various types of myomectomy which are actually not important for examination, but then you need to learn this as we are learning the fibroid as such. So the four types are hysteroscopic, laparoscopic, abdominal, and the robotic myomectomy. Is that clear? Yes. So now, so as I told you earlier, this is a minimally invasive procedure. Yes, because we are preserving the uterus. The uterus is actually preserved. And at the same time, the fibroid is also removed from the uterus. So fibroid is also removed. So now, can I ask you one more question? Which is the most minimally invasive type of hysterectomy among the types of hysterectomy I taught you now? The most minimally invasive type could be hysteroscopic myomectomy. The answer lies in the term itself, because in laparoscopic myomectomy, let's say for example, this is the abdomen of the patient, and through one port you have to create a port in the abdominal wall, and you're going to insert the laparoscope, and through another port you have to insert the surgical instrument. So ideally you are artificially creating a port, and through this port you have to insert the instrument, and you have to create a pneumoperitoneum in order to achieve a clear view of the pelvic structures as well. So laparoscopic myomectomy is a conservative management, but then you are actually creating some ports and you are introducing the instrument inside the abdominal wall. But when compared to this laparoscopic and abdominal, hysteroscopic myomectomy is when through the natural orifice, that is through the vaginal orifice, you are inserting the hysteroscope and you are removing the fibroid which is present in the uterine cavity. So you are not performing anything invasive in hysteroscopic myomectomy. At the same time, you are not making any port here, you're not making any incision here. So hysteroscopic myomectomy is the most minimally invasive type of myomectomy when compared to the abdominal as well as the laparoscopic myomectomy. Sorry, we have a small correction here. This is myomectomy. So the most minimally invasive type of myomectomy is hysteroscopic myomectomy, because through the natural orifice you introduce the hysteroscope and you are going to remove the fibroid which is present in the uterine cavity. Whereas in laparoscope you are going to create a port, and through that port you have to introduce the instrument and you have to create a pneumoperitoneum in order to get a clear view of the peritoneum, and then you are going to remove the fibroid as such. So the complications could be whatever complications you could anticipate in laparoscopy procedure as well. And in abdominal myomectomy, you're going to create an incision and followed by the removal of the fibroid, you have to suture it. So when compared with all these types, hysteroscopic myomectomy is the most minimally invasive type of myomectomy. Is that clear? Yes. So myomectomy is all about removal of the fibroid. Removal of fibroid. Ideally, we need to call this as enucleation of the fibroid. Enucleation is nothing but you can compare it to an ice cream scoop. An ice cream scoop is actually used to scoop the ice cream out from the ice cream box. Similarly, this fibroid is removed similar to an ice cream scoop, where you are going to enucleate the fibroid from the uterus. At the same time, you are going to preserve the uterus as such. So it is actually enucleation of the fibroid with preservation of the uterus. Is that clear? Yes. So what is the actual use of this myomectomy? In which patients you can consider this myomectomy? So myomectomy can be considered in a patient who is belonging to the reproductive age group. Why? So any female who is belonging to the reproductive age group, myomectomy can be considered as an option. And any patient who is having infertility due to submucous fibroid due to submucous fibroid, any patient who's having infertility, and any patient who wants to conceive in the future. So if the patient wants to conceive in future, definitely you cannot perform any invasive procedures such as hysterectomy or uterine artery embolization, or you cannot just start her on any hormonal management to just watch over, because she wants to conceive, and at the same time you need to decrease the size of the fibroid, or you have to decrease the amount of bleeding in that patient. So the most probable management in those females who wants to conceive in the future should be a conservative management, and the conservative management here is the myomectomy, where you are preserving the uterus, at the same time you are enucleating the fibroid from the uterus as well. And in any patient who is belonging to the reproductive age group who is having infertility, this infertility is because of the submucous fibroid, which is situated in the uterine cavity, which is acting as a hindrance to the ascent of the sperm and the implantation of the blastocyst in the uterine endometrium. So in case of submucous fibroid, which is causing infertility, that has to be removed in order to get proper implantation and proper ascent of the sperm for fertilization. So therefore this fibroid has to be removed by conservative myomectomy. So once you do myomectomy in this patient, after few months there could be chances that this patient can get conceived spontaneously without any artificial modes of reproduction. Is that clear? Yes. So therefore the indications would be the most important indication. Indication is the patient wants to conceive. The patient wants to conceive in future. Right? The family of the patient is not completed. And the second would be any reproductive age group female. Reproductive age group female with infertility. This infertility is due to submucous fibroid. Right? So in all these patients you can consider myomectomy as an option, but at the same time you should not consider this myomectomy in a perimenopausal or in a in a perimenopausal age group female, or those females who are more than 40 years of age, who have completed their family, have completed their childbearing, everything. You need not consider myomectomy as an option in that patient. You can consider uterine artery embolization, you can consider the magnetic resonance focused ultrasound, or you may consider the hysterectomy as an option in that patient. You need not consider myomectomy, because myomectomy is a conservative approach where you're going to preserve the uterus, but there is no need to preserve the uterus in a patient who has conceived and who has completed their family. So most probably more than 40 to 45 years of age, the patient has completed the family, you can just remove the uterus in that patient, right? But if the patient hasn't completed the family, having infertility, reproductive age group female, you can consider this myomectomy as the sole treatment of choice in fibroid. Is that clear? Yes. And what are the contraindications? Contraindications are pregnancy. If the patient is pregnant now, you cannot do this procedure. And any kind of active pelvic infection, pelvic inflammatory diseases, you cannot do this procedure. And if the fibroid is asymptomatic fibroid, because there is no clinical evidence that you have to treat an asymptomatic fibroid. Unless and until the fibroid is silent, and as such you need not disturb the fibroid. So asymptomatic fibroid, you need not do anything. Is that clear? Yes. And in postmenopausal female, as I told you earlier, in postmenopausal female, the fibroid itself will shrink as the female is going to cross the menopause age, because in menopause there is going to be decrease in amount of estrogen and progesterone in her body, and fibroid is predominantly estrogen and progesterone dependent tumor. As the level of estrogen and progesterone is going to decrease in her body, the fibroid will eventually shrink in size and necrose. Is that clear? Yes. And any patient who have completed their family, which is also known as more than 40, or either in perimenopausal age group female. In perimenopausal age group female also, you should not do this treatment, because myomectomy is a treatment option to preserve the uterus. To preserve the uterus, it is the conservative management. But in perimenopausal age group patients, there is no need to preserve the uterus, because ideally the patient is going to end up in menopause in 2 or 3 years. So you need not do myomectomy in such patients. Is that clear? Okay. So now, what are the complications? The complications could be, the most important complications could be hemorrhage, because you're removing the fibroid. Fibroid is highly vascular because the blood supply which is supplying the fibroid is situated in the pseudocapsule. So since the fibroid is a vascular tumor, benign tumor, removal or the enucleation of the fibroid from the uterus can lead to hemorrhage. So hemorrhage is the most common complications, and in certain cases it can also cause failure of management or persistence of fibroid. Persistence of fibroid in spite of the surgical management. In spite of you have done the surgical management, there could be persistence of this fibroid as well. So it is actually failure of the surgical management could be the complication as well. And in certain cases, because of incision, there could be adhesions being present as well. Adhesions of synechiae could be present as well. The most common complication would be hemorrhage, followed by persistence of the fibroid or adhesions due to the incisions which you are going to make in order to remove the fibroid, right? This could be the complications. So as I told you, the most common complications would be hemorrhage. In order to decrease the amount of blood loss in that female, what are the anticipatory effect you're going to take before the procedure of myomectomy? So pre-op evaluation should include the evaluation of hemoglobin as well. If the patient is going to be anemic, you have to consider giving iron to her to increase her blood levels. Right? Along with iron, you are going to give GnRH analogs, GnRH, gonadotropin releasing hormone analogs. If given with iron in the pre-op period, this would lead to a rapid increase in the level of hemoglobin in that patient. So even before the procedure, you have to start giving GnRH analogs along with iron to the patient in order to result in increase in amount of hemoglobin in her blood. Only then you can take her for the procedure of myomectomy. Is that clear? So preoperative management has to include the complete blood workup. You have to do the CBC as well. If there is sort of infection, give the antibiotics. Prophylactic antibiotics has to be done. IV line has to be secured. And you have to keep in reserve 1 unit of blood for transfusion. So check everything and then take the patient to table for the procedure. So pre-operatively, you have to just make sure all these things are available as such. And now, what are the intraoperative steps you're going to take in order to prevent the hemorrhage? So the intraoperative steps could be, you have to give hypotensive anesthesia. So the anesthetic agent should be a hypotensive anesthesia. Why? Because it's that hypotensive, we are going to create hypotension, because hypotension will cause vasodilatation, and vasodilatation will prevent the excessive amount of hemorrhage in that patient. Is that clear? Yes. And the second step would be, you have to keep the blood which was ready for transfusion. Transfuse 1 unit of packed red blood cells. Transfusion. By that you can decrease the chances of massive hemorrhage being happening. You are going to load the patient with 1 unit of blood transfusion so that you can prevent the amount of blood loss from the patient. The hemoglobin level will be maintained, right? Yes. And then you can inject some vasopressor agent inside the pseudocapsule of the fibroid. Inside the pseudocapsule of the fibroid, which will cause vasoconstriction right, in the fibroid, which will decrease the blood supply to the fibroid as well. Is that clear? Yes. And you can also use some clamps. What are those clamps you're going to use here? So the clamps could be either a vascular clamp, to the uterine artery. So what is that clamp? In order to decrease the amount of blood loss during the procedure of myomectomy, and that is the Boney's myoma clamp. Right? This is the Boney's myoma clamp. So this clamp is actually used to clamp the uterine artery, which is the major blood supply to the uterus as well. So once you do the procedure of myomectomy, where you're going to enucleate the fibroid from the uterus, this is going to decrease the amount of blood which is entering the uterus as well. So you clamp the uterine artery with the help of this Boney's myoma clamp. If this is not available, you can use a simple tourniquet as well. Clear? Yes. So we have discussed about the intraoperative steps, where you can give hypotensive anesthesia can be given to the patient, right, which will prevent the massive hemorrhage, and you can give transfusion of 1 unit of packed red blood cells, which will prevent the amount of hemorrhage from the patient. And also you can inject some vasopressor drugs inside the pseudocapsule of the fibroid, which will decrease the amount of blood supply. And you can also clamp the uterine artery, which is the major blood supply to the fibroid, with the help of this Boney's myoma clamp, or with the help of a tourniquet. Right? Yes. So these are the intraoperative steps which you are going to take during the procedure of myomectomy in order to decrease the amount of hemorrhage happening in that patient, because the most common complications you have to anticipate in the treatment of myomectomy is hemorrhage. So to prevent the hemorrhage, do the pre-op management as well as the intraoperative management as well, where you're going to keep 1 unit of packed red blood cell blood for transfusion ready, and you can apply the clamp, tourniquet, and hypotensive anesthesia, inject some vasopressor drug into the pseudocapsule of the fibroid, and everything, right? Pre-operatively, you can give blood, you can give iron with GnRH to increase the amount of hemoglobin in that patient, so that the iron reserves are not lost, and the patient is just stable as such, right? Okay. Now what is this instrument you see here? This is the Boney's myoma screw. So this Boney's, as you can see here, this is a screw. So Boney's myoma screw is used to hold the fibroid during the procedure of myomectomy. So whenever you see the fibroid, right, this Boney's myoma screw is actually used to hold the fibroid during the myomectomy. So we have discussed about 2 instruments here. One is the Boney's myoma clamp, and the other thing is the Boney's myoma screw. The clamp is used to clamp the uterine artery, which is the major blood supply to the uterus, and the screw is used to hold the fibroid during the procedure of myomectomy. Is that clear? Okay. Now, what is the success rate of this procedure? The success rate is that 80%, 75 to 80% of the patients, the procedure is successful in terms of symptomatic relief. The patient is going to be symptomatically relieved. Like, there is going to be decrease in the amount of bleeding which is happening in that patient, decrease in the pressure symptoms that is being experienced by the patient, and there is going to be the dysmenorrhea is not going to be present. The patient will be relieved from the pain during menstruation, relieved from the pressure symptoms, and the patient will be relieved from heavy menstrual bleeding, and there could be chances of the infertility getting corrected, because you are removing the fibroid which is present in the submucous fibroid which has been present in the uterine cavity. Since you are going to remove the fibroid which is present in the uterine cavity, the fertility is just preserved in that patient. So once you remove the fibroid from the uterine cavity, there are high chances that this patient could again get pregnant in a period of about 6 to 12 months after this procedure, where there will be success of implantation of the blastocysts in the endometrium, right? So 75 to 80% cases it could be successful, but then around 20 to 25% of the patient, they would require revision of the surgery. Why? Because is that even after performing this procedure, there could be persistence of this fibroid as well, or that could be recurrent fibroid as well. So either it could be a persistent fibroid or either it could be a recurrent fibroid as well. So ideally 25% of the patient would require another attempt of myomectomy to be done. So in about 80% of the cases it is going to be successful in terms of symptomatic relief, but in about 20 to 25% of patients a subsequent surgery would be needed. Is that clear? Yes. So now, when can the patient plan the pregnancy after successful myomectomy? So once the myomectomy has been successful, the patient has been symptomatically relieved from all those heavy menstrual bleeding, dysmenorrhea, pressure symptoms. Now the patient can plan the pregnancy after about 6 months, right? But ideally, only after 3 months they should plan. This is very important. After the procedure, only after 3 months the patient should start planning for their pregnancy, but ideal age is around 6 months after myomectomy. So if the question is when can the patient plan their pregnancy after successful myomectomy, the ideal answer would be 6 months after the myomectomy procedure the patient can plan the procedure. But definitely after 3 months only the patient has to plan in order to decrease any sort of complications being arising. After 3 months the patient can plan the pregnancy. After 6 months it is very well the patient can plan and date the pregnancy as well, right? So anywhere around 3 to 6 months after the procedure the patient can plan the next pregnancy, which could be a successful pregnancy as well. So this is all about the myomectomy, which was a conservative management where you are enucleating the fibroid, at the same time you preserve the uterus as such. And this myomectomy can be done by laparoscopic, hysteroscopic, abdominal and robotic approaches as well. So I hope I have been very short and I gave you a gist about this myomectomy. In case if you have any doubt regarding this procedure, please write to us in the Mackler handle so that I can reach out to you as early as been possible. And most importantly, please subscribe to this Mackler handle so that you will get the daily video updates being released here. And very soon we are going to start the practical sessions in Mackler YouTube handle, where we'll be discussing about the practical cases and the daily case scenarios which are being discussed in OPD basis, right? Until then, please keep studying. Let's meet in the next